So in the next case I chose, we did case 4, and this focuses on a 58-year-old woman with multiple symptoms, which you can read in the case description. So for the first question, we talk about which of the following vitamin deficiencies is the probable cause of this presentation, and we need to discuss each option and note which deficiency is most likely. So the first option here is iron. An iron deficiency is unlikely due to the presentation of megaloblastic anemia. Iron deficiency anemia is characterized by microcytic and hypochromic. Unique clinical manifestations of iron deficiency include burning sensation of the tongue, glossitis, and cheilitis, which is inflammation of the tongue and lips, respectively, which is not seen in our patient above, so iron deficiency is unlikely. Vitamin B6, otherwise known as peroxidyl phosphate, is involved in a multitude of enzyme reactions, including carbohydrate, lipid, and amino acid metabolism. Within amino acid metabolism, B6 is a required cofactor in the process of transamination and transsulfuration. Transsulfuration is the conversion of homocysteine to cysteine through cystathione beta synthase in methionine metabolism. Peroxyl phosphate is also involved in hemoglobin formation, therefore a deficiency in B6 will lead to a development of normocytic anemia. Other clinical symptoms of vitamin B6 deficiency include altered mental status, seizures, pruritic rash, cheilitis, glossitis, and depression. The patient's profile does not align with the clinical features described here, therefore vitamin B6 deficiency is unlikely. Whereas vitamin B12, our last option, also known as cobalamin, is an essential vitamin required for homeostasis. Cobalamin is critical in the development of parts of the body, including the brain, nerves, and blood cells. Vitamin B12 is utilized in the activation of an enzyme designated for folic acid transportation into the cell. A deficiency in cobalamin results in the production of abnormally large red blood cells termed megaloblastic, as seen in the patient described above. Clinical manifestations of cobalamin deficiency include pallor, jaundice, sore red, beefy, shiny tongue, nausea and vomiting, weight loss, paresthesia, which is defined as an abnormal sensation of the skin, which can include tingling, prickling, chilling, burning, or numbness, which is seen in this patient. Other clinical symptoms are ataxia, which is a gait and balance disturbance, and possible dementia. These symptoms align with the patient described above, therefore cobalamin deficiency is the most likely diagnosis. The patient is most likely experiencing tachycardia due to decreased red blood cells within circulation, high oxygen demands within peripheral tissue in accordance with decreased oxygen carriers due to decreased hemoglobin within the RPCs leads to an increase in heart rate as a compensatory mechanism. So next, we need to discuss how this vitamin deficiency impairs purine or pyrimidine metabolism. Vitamin B12 deficiency impairs purine and pyrimidine metabolism through inhibition of folate recycling. Vitamin B12 is necessary in the conversion of storage form N5-methyl-THF to an active form of THF. A deficiency in B12 can result in an absence of the described process, eliminating the use of the storage form of folate, effectively reducing folate functionality. Folate is required for the catalysis of intermediate steps within purine synthesis. One enzyme that requires a folate cofactor is formyltransferase, which catalyzes two reactions before the production of inosine monophosphate, or IMP. IMP is utilized to generate adenylene monophosphate, AMP, and guanylate monophosphate, known as GMP. These nucleotide monophosphates are then able to be converted to diphosphate and triphosphate forms utilized in DNA synthesis. Therefore, folate is a key methyl donor involved in purine synthesis. Without this required cofactor, purine and subsequent DNA synthesis would be inhibited. Concerning pyrimidines, folate is also necessary for nucleotide synthesis. A product of pyrimidine synthesis is deoxythymine monophosphate, or DTMP, which is a required substrate in DNA synthesis. The generation of DTMP is catalyzed through thymidylate synthase and requires a carbon donation from folate. Therefore, without this key donation, nucleotide synthesis would be impaired. And lastly, we were told to list the potential laboratory tests and findings that would assist in your differential. To explain this, anemia is a condition characterized by low RBCs, hemoglobin, and hematocrit. Each of these tests is a part of the complete blood count, or CBC. Also included in the CBC are RBC indices. These indices include average RBC size, labeled as MCV, mean cell volume, amount of hemoglobin per cell, which is MCH, the hemoglobin concentration, labeled as MCHC, and red blood cell distribution width, RDW. In this case study, megaloblastic anemia was suspected with the presence of large RBC precursors called megaloblasts. Macrocytes are enlarged RBCs with an MCV greater than 100 per cell. In the presence of anemia, a low MCV less than 80 suggests an iron deficiency. This would be a microcytic anemia with associated low MCHC or hypochromic, and iron studies would suggest this diagnosis. B6 deficiency anemia is also microcytic and can be confirmed by measurement of mean plasma pyridoxal 5-phosphate or PLP concentration, which is reported as vitamin B6 or peroxidine. Xanthuric acid is elevated with vitamin B6 insufficiency. A very high MCH of greater than 115 FL per cell suggests either vitamin B12 or folate deficiency anemia. Serum B12 and folate levels would be measured next, and if low, a diagnosis is confirmed. If these levels are borderline, further testing of MMA and homocysteine are indicated. If both of these are elevated, the diagnosis of B12 is confirmed. If MMA is normal and homocysteine is increased, the diagnosis of folate deficiency is confirmed. In the presence of B12 deficiency, Schilling test can be measured to differentiate malabsorption from lack of intrinsic factor. And that is all, and have a great day.